This talk today is really sort of a collaboration between my 20-plus years of experience as a transplant administrator and really sort of having a conversation with the folks at Syncardia about finance and a little bit further along in the slides, I'm going to demo a model that we can share. But a little bit about myself first, because I'm probably the only transplant administrator in the room and in a pool full of very talented surgeons and physicians that I have really built my career in a tremendous amount of respect for all of the work that you do. I can't do the magic that you do in your doctor's offices and in your OR, but you know, I've always viewed my role as being supportive and trying to remove barriers to your success. So I am a founding member 100 years ago, all joking aside, about 20 years ago, of the Transplant Financial Coordinators Association. And I'll tell you a funny story. I've been doing this long enough that I remember a time when I called to get a authorization from Blue Cross Blue Shield of Illinois for a kidney transplant and was denied, being told that it was experimental. So as much as I may look young, I hide my grays with, with a great hairdresser. My role on the board is an interesting one. So I just cycled onto the board this past July. The term that I have is a 3-year term, and my position is actually patient and donor affairs representative. My mother was a deceased donor 12 years ago at 58 years old. My uncle was a live kidney donor 2 years ago, donated to his wife. And so I always try to keep some balance in the work that we do and the conversations that I have with remembering this very precious gift that we're given by both the deceased donors and the live donors. And trying to make sure that we really kind of keep our guiding principles, you know, with their gift and their voice in this in mind. So with that, I'm going to start with a little quote. So I found this somewhere. Tell me and I forget, teach me and I remember, involve me and I learn. And so I think as I go through the slides today, I would love to have a conversation, if not, you know, in the room now, certainly over the break and during lunch, about the finances involved and really how it's a very complicated process. So my relationship with Syncardia actually started with a conversation that I had with Pete about how I think that you guys do have a voice in this work and that the administrative perspective is something that I think adds value to everything that you can take back to your individual centers. And again, from my perspective as an administrator, what can I do to remove those barriers to my clinical partners? And hopefully today I'll show you some stuff that will resonate with you and we can certainly have further conversations. So the economics, right, pretty easy. There's costs and then there's reimbursement. That's kind of the world that we live in, right? There's direct costs like the actual product that we're talking about here. SAC fees, right, which are always ever increasing. I actually had a conversation with Dr. Skipper last night after dinner, and I said, you know, I feel like as administrators, we're always putting pressure on our teams to reduce costs, but the reality is unless there's total transparency around the variable costs, how can we really even partner and empower you to come back to us and say, hey, maybe these are some ways that we can help reduce costs, or here's some thoughts that we have around it. I think as facilities, and as the more I kind of do some consulting, I think there definitely is a culture, at least in this country, to keep clinicians in the dark about the finances. I believe in a very different doctrine, which is total transparency is where the real magic will happen. So I will preface all of this and almost give a disclaimer to tell you that I think that this doesn't exist everywhere, where you can take my talk and maybe generate some thoughts and go back and have a good conversation. I realize that there are certainly some barriers regarding that. But if we can educate all of you a little more into our world, you know, maybe we can help to kind of bridge that and really become trusted partners in the work that we do. So the reimbursement side, obviously we have the DRG, we have the Medicare cost report and outliers. So I'm going to jump right into the cost report, right? So what is it, right? I had a physician once said to me, and he would say it over and over and over again for years, the Medicare cost report fund, the Medicare cost report fund. And I said, Listen, doctor, it's not something that comes out of the foundation. It's not a pool of money that sits out there for us to tap into that, when we have a patient that has poor insurance, like, let me just go ahead and write a check for, $500,000. The Medicare cost report is actually a function at the institution level, right? So every institution that's Medicare approved and every transplant program that's Medicare approved will have a line item on the cost report that they submit information to. So why is it important? Because the cost reports actually truly and directly impact reimbursement. These are actual dollars that come back to the facility. And how does it happen? Well, it happens because transplant centers work up patients in the evaluation phase. And you'll see, I believe it's in the next slide or the following slide. Well, why do we do that? We do that because Medicare is a major revenue stream for hospitals, right? No surprise there. They pay hospitals for services based on the organ acquisition reported on the cost report. And we kind of highlighted here, and Mike did a really good job of sort of reminding me that, per transplant, when we actually get those dollars back from Medicare, I mean, can you imagine what you could do with that kind of money, right? How many people you could hire and what you could actually do with it? So again, this is an average. This is not specific to any, transplant center or any program, but you can see the impact on it. It's one of the few service lines that's reimbursable through this. So unlike any other service line, where orthopedics, trauma, bariatrics, their cost is a one-to-one cost. So when they hire somebody for $50,000, it costs them $50,000. And I'll explain to you in a little bit about how that coordinator for $50,000 or $100,000 really is not truly a one-to-one cost. So Medicare reimburses hospitals across the continuum in transplant by paying a DRG. And again, the costs included in the cost center are related to determining suitability of a candidate for organ transplant or live donor. So I'm going to let you read this slide as I pop up the next thing. So what a lot of people really forget, and why we as administrators work so hard to capture every single penny in the pre-transplant phase, it's because everything that we do to these patients and potential live donors is not diagnosis, and it's not treatment, right? Why do you give a colonoscopy to potential heart transplant? It's because you want to know if they're going to be a good candidate to put on the list or to remain on the list, not because you have diagnosis or treatment, right? And so that's a very different business model in our service line than anywhere else. When I do a chest x-ray in a potential kidney patient, it's not because they have symptoms, it's because I'm evaluating them. So Medicare understands that as a transplant center, we need to accumulate all of those costs as the organ acquisition cost center because we can't bill them. If I send a bill for a chest x-ray on a potential kidney transplant patient to Blue Cross Blue Shield, they're going to say, well, what's the diagnosis and what's the treatment? And I'm going to say, I don't have one because it's evaluation services. So what we do in the pre-transplant phase and why the Medicare cost report is so important is exactly for this reason. It's because the things that we are doing in evaluation services are the dollars that we're going to get back on the Medicare cost report. So in addition to the DRG and the Medicare cost report, there's a Medicare outlier payment. And you'll see as I go through a little bit of the model why it's important for us to make decisions. And full disclosure, I'm not clinical, and as somebody else mentioned, it's not really my role to advise on clinical pathways. But, I think as you think about these patients, I would like for you to not sort of be stuck in a certain sort of box or bucket of, I need to get patients out of the hospital. I need to do this, I need to do that, because I know my administrators are gonna say to me, I'm not making any money. Right? And I think, as Pete had mentioned, there is a compelling argument to total artificial heart does make money. And how you manage the finances involved in it can absolutely be a very different game-changing conversation at your center. Okay.
Can you comment on the last statement that you have there? I think that's crucial. In the case that the patient is not discharged, because before libation, we send the patient home for 30 days prior to bringing them back or releasing.
Yeah, so let me jump right into the model, and I think if it doesn't become clear, yeah, let's absolutely take an extra minute and talk about it. And it has to do with the Medicare outlier payment, right? And the Medicare cost report reimbursement that you get back. Those are sort of the elusive, you'll hear from your CFOs, well, Blue Cross Blue Shield is gonna pay us, $700,000, regardless, because it's just for the inpatient stay from the time they come in, whatever you do, it's a global payment. But again, I think the model will help to explain some of this. So, again, with full credit to Mike and Todd Seeger, who I have a great deal of respect for, is really a reimbursement expert in the MCS world. The two of them put this model together, and when they shared it with me, I said, yep, this feels good. It makes sense to me. It's a tool that we can use. But the very first question that I had was, where did you get any of these numbers from, right? Because that's the first question that you're going to get when you take some of this information back. So the reality is that this is a model that's built on a lot of assumptions. And my, call to action following this talk is for you to partner with Syncardia if you think that this is valuable information for you to have conversations internally. And so given that, the expectation is you will go back to your centers and plug in your actual numbers, right? So this is absolutely an example that's by design. This is not meant to sort of project this is what everybody's program looks like. But it kind of, for today's purposes, gives you an opportunity to kind of see what the numbers would look like as we walk through a typical case. You all love case studies. This is sort of my administrative version of a case study, if you will. Okay, so let's jump right in, right? So in the first example, ECMO to TAH to transplant, right? And, Catherine and Mike may throw something at me, but I'm gonna jump right on down to the bottom, right? Because this is what we get told all the time. And, transplant doesn't make money. The implantables don't make money. And I think in this particular scenario, that supports that argument, right? And there needs to be some recognition to that. We can't go to our CFOs and say to them, let's have a different conversation, when we do know that if we have a particular case where we have a 4-day ICU stay, maybe 30 days in the step down, we're gonna get about $300,000 from our private payer, the Blue Crosses of the world, if you will. We're going to get a Medicare outlier payment because we know that Medicare, above a certain threshold, will then kick in a % of charges, right? So I think that speaks to your question a little bit, but let's keep walking through it, right? So there's your total cost, right? About $350,000. And then you have some additional costs, or that's your reimbursement, I'm sorry. Then you have your direct costs, right? So you have the cost of the product, some other things related to it. And fast forward, all of a sudden that patient lost us about $60,000 for the institution. And I'm knocking on your door saying, Dr. Hooker, and I don't think I did, but because I come from a different doctrine, which is, again, stratifying your patients, not only from a medical, but also from a financial standpoint, is ultimately where we need to keep our true North Star that we aim towards, right? We can't have a program of only Medicaid patients, but we also can't have a program of just commercial payments, because I think then we're not serving our community. And that's something, again, going back to my position on the board and representing patients and donors, is not something we ever want to get in the business of truly making doctors say, well, they're a good candidate, but what's their insurance? I want to know what their insurance is, because I know somebody's going to yell at me or, rack my knuckles if I don't do enough of the good insurance patients. And so, fast forward, if we look at the private pay, it's a little bit of a different story, right? We're getting a much larger payment, right? Because hopefully you're partnering with your C-suite financial folks and have a voice in the conversation about negotiating transplant contracts and what's included in those contracts. So how much we can include pre-transplant costs, how much we can be sure that we write language that says if we decide that an implantable device is in the best interest of a patient, that you, commercial insurance, will pay for it, right? And that we don't assume that financial risk on the transplant side, on the center side, right? And so we're not going to get a Medicare outlier payment because they're not a Medicare patient. They're a strict commercial, right? And so all of a sudden, it's a very different financial picture, right? And I would argue that, if you do 2 patients only at your center, and those are the 2 that you do, you're still going to come out way ahead financially. You're going to make the me's of the world thrilled, and I'm going to say, I want more of you. Let's do more of this, right? So let me fast forward, because again, I think the takeaway is really, what I'm trying to drive to this morning. So different scenario, right? So we have now maybe 10 ICU days and 2 weeks in the step down. Same DRG payment, right? I'm staying in the first column, so about $203,000. But now all of a sudden we layer in all of those dollars that we're going to get back through the Medicare cost reporting process, right? So we're capturing all of those evaluation charges, all of the cost of, y'all do time studies, right? I need to see you shake your head, right? All of the cost of the pre-transplant coordinators, the cost of the computers they use, right? All of that pre-transplant stuff is not diagnosis or treatment. And all of a sudden, now a facility is getting dollars back in any given fiscal year. So let's take the same scenario, right? So now we have this bolus of $250,000 being fed into the reimbursement, and all the way down to the bottom, and I'm just going to fast forward, you don't see negatives anywhere, right? So I take very personally when my CFOs come to me and say, transplant loses money, do less of them. I'm a girl, I cry, right? So that makes me want to go back to my office and cry and say, this is a totally wrong conversation. We need to be partners in this. We need to empower the physicians to understand our world. We need to be educated as administrators to be able to teach and talk to everybody involved in this conversation. Really good friend of mine recently said, you're either, at the table, you're part of the meal, right? So I think you're part of the meal in that $58,000 loss, right? You're the one that's being called in and saying, you're a money loser, what are you doing? And I know you guys are exhausted, you're working, and you're saying, how could this possibly be? And it's because unless you're extremely smart and partner with good people that understand how to capture every single reimbursement that you're entitled to, this is what the conversation will look like. And instead, I would say, let's partner with our folks at Syncardia. Let's bring them in to your group, to your C-suite, and plug in your actual numbers, right? So don't just take our word for it. Don't just take Mike's model for it. Let's plug in your numbers and see what this would look like, right? Because as clinicians, if you want to continue total artificial heart or you want to get in the business of it, this has to be part of your conversation. You have to be able to speak to some of the finances of it. So this slide and the next one is just a replication of the last 2 slides. It's just shown a little bit differently and a little bit sort of simpler. So I'm going to kind of fly through these pretty quick.
If you go back,
Yes.
so that one was the example where you keep the patient in for a full 60 days before transplant on the far left. And you can see the 145,000 bottom line number only goes down to 117 because the additional outlier kicks in, replacing what would have been a second DRG. So economically not bad.
Yeah. Thanks, Mike. Thank you very much. So if I leave you with nothing, I want to leave you with this, right? again, you're at the table, you're part of the meal. Engagement is imperative. I think one of the first things I said to Pete when I met him for the first time, and we had, a very long discussion about everything, finances. I'm talking a little bit about the UNOS updates and the allocation. And, at the end of the day, one of the takeaways from that conversation, I asked Pete, I said, have members of your team go to the regional meetings. Right? They're public meetings. Go to the UNOS meetings, hear about what's happening with allocation, understand and talk to your colleagues that are using this device, struggling with this device. Again, they want to do it, but they're kind of, administration isn't on board with it. Get out there in our community in a way that's different than sort of the, sales rep making a meeting, right, to meet us in the office. Come to our regional meetings. They're twice a year. Be part of the conversation. You have to engage, because if you're not engaged, you're not relevant. And in today's day and age, as quickly as things are moving with allocation changes, financial reimbursement, how payers are going to pay for things in the future, you have to have a good partner in the administrative level to make sure that we're representing the best interests of what we're trying to do for our patients. So why is this important? So again, healthcare teams are always trying to seek ways to contain costs. It's the question that I had. Hey, doctor, you spend too much money. My doctors go, well, what do you want me to do with that? If you don't tell me how much drugs cost, what am I going to do? Give one less pill to my patient? If you don't tell me how much OR time costs, if you don't help me understand how just reducing half a day ICU stay results in $100,000 of savings, it's irrelevant to me. And I think we have put you guys in that position to sort of shut down and be like, you know what? You don't share the information with me, so what do you want me to do about it, right? So we're always trying to seek ways to contain costs. I think this tool, again, just a snapshot example, not meant to be set in stone, can assist and help with that conversation. Allocation changes. Again, I've heard it all morning, and certainly my talk in another hour or two will touch on some of that. And I think being able to be proactive in understanding that not only are we now 1 year post heart allocations, but what is being discussed at the local, regional, and national level regarding allocation in the years to come. You'll see in one of my slides this afternoon about the directive for continuous distribution, right? So we need to be having conversations now with our teams, with our C-suite, with our community partners that refer to us about having the conversation of the patients who we transplant today are not the same as they were a year ago. And guess what? When the system rejiggers again, it's going to be different still. So how do we have those conversations today with the finances to make sure that we, have good partnership? So from my perspective, who needs to be involved? I mean, certainly the docs. I mean, that's a no-brainer. Folks like myself, right? But I think certainly your financial director, right? I think every transplant center probably has a financial analyst or a business partner. Certainly your CFO, if your center is open enough so that you can, again, talk about those variable costs and what it means when they negotiate contracts with the big payers, right? So we had a contract at one center that I worked with that the lowest payment was if we discharged a patient within 14 days. The highest payment was if we kept them in greater than 30 days. So it disincentivized good outcomes, right? If we can have a great outcome and we can get somebody home in 2 weeks, we got the lowest possible payment. There was a donut hole in this contract. And so then we were like, well, shoot, we'll just park them in the ICU for 45 days because we'll just continue to rack in those payments and, and those percentage of charges. I mean, so again, I think it speaks to you need to have engagement with your CFO to make sure, right, because from their perspective, they're like, oh, the longer the patients stay, the more money we make. But it's completely counterintuitive to what we're trying to do. So very imperative. And I think your quality director, your quality coordinators can also have a very valuable voice in, again, those things. What does it mean from an outcomes perspective if we can get people out of the ICU sooner, if we can get them home sooner? What does it mean financially if we get them home pre-transplant versus if the entire stay, they come in, they get an implantable, they stay for transplant, and then we get them home. And I think that that's where the outlier payment kind of kicks in. It's the longer that they're here, there is a Medicare outlier that goes into a percentage of charges. And so, again, being savvy enough to understand all of this and being engaged enough to want to learn about it is very important. So I touched on this already, have conversations internally. That would be my hope of this morning. And if you feel that this information is valuable to you in your practice, partner with the folks at Syncardia. Like I said, Mike has built this beautiful model that I think would be, very relevant to everything that you do. So with that, I'll take a pause. Yeah.
Thank you very much. That was a great presentation. I cannot emphasize how important it is for us, the users, to have transparency with the C-suite, the hospital administration about what is really going on. Otherwise, believe me, we are kept in the dark and decisions are being made and we don't know. It's crucial that we interact, we ask questions to fully understand the Medicare cost report, which is always kind of an unknown cloud out there that they kind of throw at you in the meetings and you don't understand too well. And the other one is the outliers. And along with that comes, that is crucial from our standpoint, from the user, the correct documentation of complications in the progress notes to make sure you get fully reimbursed.
Huge.
That is huge. And that is
That's
something.
a game changer.
It is a game changer.
Absolutely.
If you understand that, that is crucial. And then, Mike, I want to tell you that those numbers that you have there, in my prior life in Los Angeles, they're extremely accurate. They are extremely accurate. And that's why part of the reason TAH became such a big thing in some centers in LA, because it was, from a financial point of view for the institution, it was, they were not even aware of it until it showed up. So,
Kim
Yes.
actually educated me on something in addition to building up this meeting, where, so the way the Medicare cost report works is you accumulate all these costs in your filing, and then you're able to get reimbursed pro rata for Medicare eligible
Yes.
transplants that you do. So if your
Right.
center does 20 transplants, even if only 10 of them
Are
are
Medicare
Medicare
primary.
payer,
Yeah.
there may be 19 of them that were all Medicare eligible.
Right.
So you get 19/20ths of what you put on the Medicare cost report.
Right.
And
It's-
that's why we show that Medicare cost report benefiting both the Medicare and private pay patients.
Right. Thanks,
So
Mike.
it's a significant revenue stream.
Yeah. So the Medicare cost report, and again, we can just for fun, during the break, read the regs on all of this. So what Medicare allows is this accumulation, and it is a complex ratio. When I shared it with Mike, and Catherine, they were like, "Boy, we would love for you to explain this." And I go, "Yeah, me too. 20 years in, so it's very complicated. It's how many transplants that take place at your center, coupled with how many donors are actually procured at your center, equals Medicare organs. And the long and short of it is it's a ratio. And the ratio is based on Medicare eligible patients, not Medicare primary, not patients who will get Medicare. It's Medicare eligible patients. And as I shared with Mike and Catherine yesterday, in my entire career, I've known 2 patients that were not Medicare eligible other than the foreign nationals, right? So it was a gentleman who was an artist and had no verifiable income his entire life, so he had no work credits to be able to qualify for it. The second was a woman who came from a very wealthy family, went on to marry very well off, and then got divorced and had kidney disease and could not qualify for Medicare because she had no work history, right? So Everybody else, particularly in the pediatric world, I look to my pediatric colleagues, most of the kids can get Medicare through their parent pathway, through the parent work credits. So other than, again, the foreign nationals in our current state of our, country, if you will, almost everybody is Medicare eligible. And so that's a very different conversation. Yes, sir. So Medicaid, what I would say for the purposes of this talk, falls into the commercial payer, right? It's just that number is going to be far different, right? That's probably going to be 100,000, right? Because the Medicaids, most of them are managed Medicaids, which really puts them sort of in the commercial bucket, if you will.
But wouldn't the Medicaid transplant be, big one that you also get your pro rata reimbursement from the
Yeah, because it's Medicare eligibility, right? So again, we're not talking about who is the primary payer for you fill in the blank, the length of stay, for the implant, for the transplant, whatever the case may be. But it's, right, because it's not about who the primary payer is. It's about how many Medicare eligible patients do you have, and that filters into the ratio of how many dollars you get back.
I think most of us who do this, even some of us that are in leadership positions, are heavily underinformed about this topic.
100%.
Feel
Right. I gave that
manipulated
disclaimer
in
that
some
I
ways.
realize that this is, rampant.
But yeah, no.
Well, it's intentional, right? Because if we tell you what you make, you're going to ask for more money.
Yes.
Right? Like,
So it's a question about the Medicare cost report. And the costs, the stuff that you described that goes into calculating the effort that goes into the pre-transplant process, we spend quite a bit of time on a number of evaluations that don't go
Don't
to
go
heart
anywhere.
transplantation or get a full evaluation and are turned down.
Yeah.
How do they account for that? And are those,
it's all included.
they're all included?
It's all included, because if it's pre, right? Because that's exactly why, right? So Medicare knows that at the time of transplant, we don't know who the actual payer is going to be, right? Because it could be years. I mean, if you have a great referral source that refers early in the disease process, it could be years before somebody actually ends up with a transplant. And gosh, I don't even know what my benefits are going to be in another 3 weeks. And yet we're asking patients and we're asking systems to know what patient's insurance is going to be at the time of the event. And so this is, again, very unique to the transplant service line, but it's intentional because we know that we need to work up patients, and it's for evaluation only. It is not diagnosis and treatment. If I send a chest x-ray for a kidney patient, insurance is going to kick it back. They're going to say, what's the diagnosis? And I'll say, evaluation. They go, no. Like they only pay for those reasons, not for evaluation. And so that's why Medicare allows for this. And so that's why Medicare approved centers have this functionality to be able to accumulate those costs and then get them back as real dollars.
Yeah, so effectively, all the evaluations you do go into this, my understanding, all the evaluations you do
Yep.
on all your patients, even not transplanted, go into this
Right.
accumulated cost bucket.
Yep.
That is then paid out to you pro rata based on
The
the
ratio.
Medicare eligible transplants compared to your total transplants.
Yep.
So you can recover all those evaluations. We
Right.
boiled it down to a per transplant so we could look at the whole economics of
Right.
a
So,
patient.
so let me make it a little bit relevant to you guys, right? So you cath somebody, right? Because you want to get those values and you want to see what value there is in terms of can this patient survive transplant, right? But while you're in there, you decide to stent the patient, right? The cath, Medicare cost report. The stent, billed directly to the payer, right? Because the stent is a procedure. There's a diagnosis. You're going to have a diagnosis, right? Blockage or whatever. Documentation, imperative, right? But the cost of the cath lab, getting the patient in there, the anesthesia, whatever you want to do, those charges are all allowable on the Medicare cost report.
And that's why I was saying that if you put a cardio lens in, because you're trying during the hospitalization as an evaluation tool to see if they're actually eligible might have variability, that you could actually claim it in this bucket.
So I see a lot of folks standing in the room. They'll be handing out a quiz now. No, but I really appreciate and can't thank you enough for listening to what I have to say. I'm always in awe by the partnership that I can have with some of the physicians and surgeons that I've had in my career. So thanks to all of you for all the magic that you do to save these patients. I'm very blessed to be here and in your presence. So thank you very much.